welcome to another MOGCast entitled Understanding the Differences Between MS and MOGAD and How the National MS Society MS Navigator Can Help. Today we're speaking with Dr. Tanuja Chitnis and Abigail Vacca. My name is Julia Leffler, Executive Director and co-founder of the MOG Project. We're a US-based nonprofit organization devoted to raising awareness, advancing research, and providing support and advocacy for the MOGAD community in hopes of finding a cure. We would like to thank our guests and the MOG Squad for their contributions to this MOGCast. The MOGCast is being recorded and will be available on our website, Facebook page, and YouTube channel. If you want to submit questions, unfortunately, we are not able to connect. We've had some technical difficulties, so we're going to collect questions after the MOGCast that went unanswered, and we're going to provide that in a follow-up MOG blog. I'm really excited to introduce Dr. Tanuja Chitnis. Dr. Chitnis is a professor of neurology at Harvard Medical School, senior neurologist at Brigham and Women's Hospital and Massachusetts General Hospital, and senior scientist within the Ann Romney Center for Neurological Diseases at Brigham and Women's Hospital, where she created the Translational Neuroimmunology Research Center, focused on bringing bench discoveries to clinical trials for MOGAD, multiple sclerosis, and neuromyelitis optica spectrum disorders, also known as NMOSD. She created and serves as the director of the Partners Pediatric MS Center at the Massachusetts General Hospital for Children. She's published over 250 scientific studies, including key publications on MOGAD phenotypes and biomarkers. She receives grant funding from the Department of Defense, NIH, the National MS Society, and the Guthrie-Jackson Charitable Foundation. She's the recipient of several awards, including the Joseph Martin Award for Clinical Research in 2019 from the Scientific Advisory Council at Massachusetts General Hospital, and the 2018 Milestones Award from the National MS Society. In addition to her mentioned positions, she's also a director of the Translational Neuroimmunology Research Center, the CLIMB study, and Partners Multiple Sclerosis Center at Brigham and Women's Hospital, as well as a co-director for the Partners Multiple Sclerosis Center Fellowship Program. So the National Multiple Sclerosis Society is a nonprofit organization whose mission is, we will cure MS while empowering people affected by MS to live their best lives. The society offers a variety of educational programs, self-help groups, and the MS Navigator program led by highly skilled, compassionate professionals that seek to connect individuals to the information, resources, and support needed to move their lives forward. Abigail Vacca, who we have here today, is a senior manager for MS Navigator Services Delivery. She's worked for the National MS Society for over 8 years and has a master's degree in social work. She's a member of the crisis and healthcare provider referral teams and co-leads their internal ERG for employees with chronic conditions. Welcome to both of you, and really thank you so much for joining us.
It's a pleasure to be here, Julia.
Thank you.
Thank you for having me.
Thank you, Abigail. Thank you, Tanuja. I wanted to, talk for the first half of this MOGCast about challenges distinguishing MOGAD from MS, and this is a really hot topic. And with the new with the new criteria, this proposed criteria for MOGAD that has recently come out, and I know Dr. Chitnis, you were one of the pivotal members of that group that came up with this. I think we want to really reflect that in some of our discussion here today. So, a lot of people are probably going to be listening to this that are come from the MS community, and so for those people, could you describe to us what myelin oligodendrocyte glycoprotein antibody disease is? And that's obviously MOGAD. Could you tell us a little bit about that?
Yes, absolutely, Julia. So you're right. That is quite a long title. So MOGAD, or myelin oligodendrocyte glycoprotein antibody disease, is what it stands for, is a demyelinating disease that affects the central nervous system, including the optic nerves, brain, and spine. and it seems to be an autoimmune disease as far as we can tell. And one of the hallmarks of this disease is the presence of MOG antibodies in the serum, predominantly in patients with this disease. Occasionally, we see these antibodies in the spinal fluid, but mostly they're found in the serum. So that is a hallmark of this disease, and these antibodies should be tested for using a cell-based assay. That's the best type of assay to detect these antibodies, the most sensitive and specific. And in addition to having antibodies, the antibodies must be present at a certain level. And now this is well laid out in the International MOGAD panel, or IMP, as we like to say, panel criteria or proposed criteria for MOGAD, that there should be antibodies measured by a cell-based assay, as well as the presence of typical MOGAD symptoms and lesions. And these include lesions in the optic nerve, in the spinal cord, or brainstem, or other typical areas. And so this is what the international panel has laid out as proposed criteria. And we hope that this will help to clarify diagnoses in people who either weren't diagnosed with MOGAD or who may be diagnosed in the future.
Okay, thank you so much for that. That's very helpful. So, as you can imagine, we have quite a few patients who come and talk to us, and they enter the MOGAD community when they were previously diagnosed with MS. Just out of curiosity, why do you feel like this is something that is occurring? For instance, is it due to the availability of testing? Is it because of more awareness with doctors, or are there other factors?
Yes, Julia, that's a very important point. And I think it's important to be aware of the fact that the MOG antibody tests, especially these cell-based MOG antibody tests that are the gold standard, only became available in the United States in 2017. They were used in other areas of the world prior to that, but really we only became able to test routinely for these in about 2017. So that's helped doctors to identify patients who likely have MOGAD. The other factor is the increased awareness. And I think groups like yours have increased the awareness of the presence of MOG antibodies and the diagnosis of MOGAD. And also there's been a wealth of now scientific literature and publications describing different patients with MOGAD and the various presentations, clinical presentations. So I think all of that has helped to increase the awareness and the ability to diagnose MOGAD. And certainly now, hopefully the international MOGAD panel criteria will further increase the awareness and the ability to accurately diagnose MOGAD.
Yeah, that's so important. And I can't tell you how excited we are that this has come out. So we'll be talking a lot on future podcasts about that very subject. I want to just ask sort of a historical question because, and it actually may be happening right now. So prior to the availability of this MOG antibody testing, why do you think some patients who actually had MOGAD that did not quite meet that MS criteria, but did meet the criteria for other disorders, why do you think they were diagnosed with MS rather than something like NMOSD or, another important one, multiphasic ADEM?
Yes, so that's a really important question and challenge. So I think it's also important to remember that the MS criteria are quite broad, and diagnosing MS rests on having the presence of lesions in certain areas of the brain spinal cord, as well as having clinical attacks or presentations that are consistent with MS. So it's really non-specific. And a lot of patients with MOGAD could meet MS criteria. It's only after the availability of the MOG antibody test that we were able to really start to distinguish patients who had an MS-like presentation or maybe technically met the criteria for MS, having 2 lesions in different parts of the brain or spinal cord, but who really did have MOG. And so I think this is a continued issue that clinicians are going to face. And as a clinician, the availability of the MOG antibody test has really changed my practice, and I do send it in the appropriate patients. Not every patient that I see, not everyone who has very typical MS, but in patients who have unusual phenotypes. And we can talk more about what those are. These could be ADEM, it could be multiphasic ADEM or recurrent optic neuritis or atypical brain lesions. Certainly in my younger patients, I send MOG antibodies quite frequently because children are more frequently diagnosed and affected by MOGAD and more than adults. So about a third of my pediatric demyelinating clinic is MOG or MOGAD, whereas about 5% of adult patients with a demyelinating disorder actually will come down with a MOGAD diagnosis. So I think it's important to keep those frequencies in mind. So not everyone needs to be tested, but certainly if there are atypical presentations. And then to your other question around why were some patients diagnosed with MS and not with multiphasic ADEM or NMOSD, I think that goes to, again, the non-specificity of some of the criteria and the fact, again, that we have antibody testing, which can increase the specificity of diagnosis, has really advanced our ability to accurately diagnose patients.
I see. That's a great answer. And you were talking a little bit about the MS criteria, even sort of talking about this work that you've done in the MOG proposed criteria. Could you get into a little more into the weeds about the presentation differences and similarities between MOGAD and MS? Is that too extensive, or can you talk to that a little bit?
Yes, no, absolutely. And this is an area I've been very involved in and studied quite extensively. So MOGAD, I think one of the main differences with MS is that MOGAD can present in very young children. So MOGAD can present in children as young as 1 or 2 years old, whereas that is extremely rare in MS. We do know that pediatric MS does occur, but usually the onset is after age 11. So any patient who's presenting with a demyelinating disorder, whether it's ADEM or optic neuritis or other brain lesions, under the age of 10 or 11, I would definitely think about MOGAD as a primary possibility. In older children, it's also a possibility. Now, there are different what we call phenotypes or presentations of MOGAD, and these seem to differ by age group. And in very young children, we see MOGAD present as what's called ADEM, or acute disseminated encephalomyelitis, which is essentially having a lot of lesions in the brain or in the spinal cord and being quite tired or lethargic. And there could be multiple different issues going on. Again, this presents in young children typically, and some of those children will have MOG antibodies and be diagnosed with MOGAD. In older children, optic neuritis is more common, and this is typically optic neuritis that affects one or both nerves. And in older children, yet older children, maybe young adults and certainly older adults, then they present with transverse myelitis and or with what was called an NMO type of appearance. So NMO stands for neuromyelitis optica, and that means that the optic nerves are involved as well as the myelitis, the spinal cord is also involved. So these are different age-related presentations of MOGAD, and within each age group, there's an important differential, which includes MS as well as NMOSD.
I see. Okay. So, you touched a little bit on some of the phenotypes that, are associated. And I guess I want to ask is, we really wanted to know what phenotypes are often confused with MS, but that may account for some of these misdiagnoses. But, you've kind of touched on that a little bit. Are there any others that you find that show up in misdiagnosed patients?
Yes, so thanks for honing in on that question. So, some of the presentations or phenotypes that are most often confused with MOGAD and MS are those that present with brain lesions. And MS typically presents with brain lesions, and also MOGAD can present with brain lesions, and there's really a lack of clarity as to how to distinguish the two without the antibodies. Now, there's some hints, and there are some features that clinicians, especially experienced clinicians, might use to differentiate the two, but that is the topic of future studies. Now, another presentation that can be similar between the two, between MS and MOGAD, is optic neuritis, also transverse myelitis. Sometimes they seem to be similar. Again, there are some key differences that have been studied and experienced clinicians will be aware of. But it doesn't always present as the extremes, and that's where sometimes we get tripped up, and clinicians might be confused about the diagnosis. So again, antibody testing is very helpful in differentiating the two disorders.
Yeah, we have many people that have approached us about this, and their neurologist in many cases is an MS specialist, and they seem to in some cases hone in on that. And so we're trying to get messages out to the community to say, hey, if you really feel like there's something wrong, if you've come up with a positive MOG antibody test and your neurologist isn't open to that, I imagine they should try to find someone else or a second opinion, correct?
I think especially if you have an atypical MS or demyelinating presentation, if you've not responded well to typical MS therapies, that's another hint that this could be a non-MS diagnosis. And also if you've had positive tests in the past and these need to be repeated with a cell-based assay. I'll just speak about the importance again of using a cell-based assay for diagnosis. What we also know is that the cell-based assay, or any MOG antibody assay, is most often positive at the time of an attack. So sometimes it does not actually help to do this antibody testing in between attacks because it might be a false negative. And then again, you might be stuck with the wrong diagnosis because the test was negative. So if you're having an attack, that is really the best time to request or make sure that your doctor is considering sending this test.
That's a great point, and one that we often hear about. So thank you for that. I mean, I think everyone should ask for that. So this next question is really important because we've heard answers to this question from some of our experts, and we'd love to have your insight and your take on this. So can a person be diagnosed with both MS and MOGAD? And if so, what are the requirements for this dual diagnosis and how common is it? Now, if not, does a MOG positive test rule out this MS diagnosis?
Yes, so I'm sure you'll get about 5 answers, 5 different answers to this question. But I think my take on this is that for 99% of patients, these are very different diagnoses, that MOGAD has a very different presentation, that the majority of patients, if they're tested with the right assay at the right time, will have what's called a clear positive or a highly positive test. And then with patients with MS, they will be MOG antibody negative and have other features of MS that are typical, such as oligoclonal bands in their spinal fluid or typical MRI lesions. Now, there's a very small proportion of people who will have features of both, and essentially they might have a slightly atypical demyelinating presentation. They may have what's called low titer MOG antibodies, and they have some features of MS and some features that might be consistent with MOG. I think this is a very, very small proportion of patients or people. If it's low titer MOG antibodies, again, I would recommend retesting, especially if there is an attack or a new event. This titer might increase and fulfill the international MOGAD panel criteria. A low titer is not enough to fulfill criteria. if it's positive and there's still features of MS, there's going to be a small proportion of patients who might fit this these presentations. I would watch and really carefully monitor treatment response. And sometimes, and it doesn't absolutely matter exactly what we name this subgroup, but we really want to understand how this group responds to treatments. And we know that there are differences in response to various treatments in MS patients compared to MOGAD. There's some that work for MS and don't work for MOGAD, and vice versa. So I would be very careful if there is a patient who has features of both, and I would be monitoring treatment response very carefully.
Okay, so that's that leads us into our next question. Somewhat, you've answered a lot of it, and this this concept of the low titer and the possibility that it actually may be a false positive at those low levels. And then you talked about what maybe some of the things that you would do. Could you give us an idea of what is considered a low titer? Okay, first of all, and also there are some countries where the titer, other outside of the United States, I should say, where the titer value is not returned. In other words, by when they take the test, they don't do that extra step of finding the titer. And then the third part, I should say, of the question is, you talked a little bit about what you do, but is there something else you would want to say that to patients, and even if physicians, if they're listening, that they might want to consider when diagnosing these patients and with this situation?
Yeah, so I think to answer this question, I'm going to go back to the International MOGAD panel criteria, and again, there's one criteria in which you have a high titer antibody and the titer is returned and it's by cell-based assay, and you have typical features of MOGAD. So that's a very clear MOGAD diagnosis. There's other situations certainly where you might have a low titer, or the titer is not returned, or it's not done by a cell-based assay or an approved assay. But of course, the neurologists are still suspicious that this could be MOGAD. So the patient and the neurologist would have to make sure that the patient has typical MOGAD features, as well as some additional criteria need to be met. And these are clinical or radiologic criteria, and the pattern of the lesions is really tantamount to this. So there's sort of a more stringent set of criteria that would need to be met if either the titer is not available or the test was not the optimal test.
Oh, interesting. In looking at MRIs, for instance, you want to compare the MRIs of patients with MOGAD, MS, and NMOSD. There's been a lot out there by physicians on this subject. What can you tell us, I guess, from a layman's perspective, and even if there are some physicians listening, what can you tell us that doctors should look for in those cases when comparing those?
Yes, so it's a great question, Julia. So I'm going to start with the optic nerves, and I'll talk about the difference in optic neuritis presentations and MRI features between the three disorders, MS, MOGAD, and NMO. So a typical optic nerve lesion in MS is short, and it probably usually involves just one optic nerve. In MOGAD, the lesions are longer. They're usually what's called prechiasmatic, or between the eyeball and the chiasm, where the optic nerves cross, and oftentimes involve both optic nerves. So that's a clue that this is MOG. Now, the NMO, and these are really aquaporin for NMO patients, tend to have lesions that are post-chiasmatic. They might involve the chiasm, but the lesions may be in the posterior optic nerves, and also sometimes can be bilateral. Now, turning to the brain brain MRIs can look different. Now, in MOGAD, we see lesions that can occur in the cortex or sort of in the perimeningeal area. The lesions can be large and fluffy, especially in ATEM cases, compared to MS, where we don't see as many of these sort of very juxtacortical or cortical lesions in the beginning of disease. Also, the lesions tend to be more well circumscribed or well defined, and also are more ovoid in appearance rather than diffuse and fluffy. And in MS, we typically like to see periventricular lesions. So we don't see those as often in MOGAD. So those are some features that distinguish the brain MRI. Now, turning to the spine, and I should also add in NMOSD, we tend to see lesions that are around the ventricles, around the third or fourth ventricle, rather than in the brain parenchyma or in the meningeal space. So turning to the spinal cord, so in MS, the lesions in the spinal cord tend to be short, tend to be sort of what we call not in the center, but eccentric. And compared to MOGAD, where the lesions are quite long, and they can involve 3 or more segments, and they tend to be more central. And there's a sort of butterfly or H sign that has been described. These lesions can be similar to what's been described in NMOSD, as well, longitudinal extensive lesions in the spinal cord. And there are some other features that distinguish the two disorders from one another. So I hope that covers a lot of the radiology of these 3 disorders.
Yeah, I think it does. And for patients that are having their doctors look at that, I think that's an important distinction. And I'm glad that you explained that. We could probably talk about that on a separate podcast by itself. So speaking again of things, you went into the spinal cord. Some patients have gone in and in their diagnosis process, I guess they're looking for these oligoclonal bands from these lumbar punctures. And there have been studies that we've seen showing this small percentage of MOGAD patients who have these. How important is this when diagnosing a patient for MS and versus MOGAD? And would that be something that would be done or should be done, just to kind of add to information about what's going on with the patient during diagnosis?
Yes, so Julie, I think especially in what I'd say are atypical MS cases, that certainly spinal fluid analysis should be done, and that includes oligoclonal band testing, which is essentially an antibody that's present just in the spinal fluid and not in the blood or serum. And oligoclonal bands are present in over 90% of MS patients, depending on their age, but almost 95% of established MS patients will have oligoclonal bands. Now, about 15% of MOGAD patients with very typical features and antibodies will have oligoclonal bands. So if oligoclonal bands are not present and you have all the other features of MOGAD, I would feel very comfortable in diagnosing MOGAD. If they are present, it does not exclude MOGAD as a diagnosis, but I would just be absolutely, cautious and make sure that you are excluding and checking carefully for an MS diagnosis.
Okay, interesting. I think I think that gives patients a good idea of why and when they do this test. Lumbar punctures may not be fun. So, I realize what patients go through when having had one myself, when they get one. Now I want to move on a little bit to talk about some treatments. And we've read that in some of these studies, treatments like interferons can make MOGAD patients worse. How critical, first of all, is for patients to rule out the MOGAD versus MS diagnosis, and how can this affect their treatment plan, first of all? And secondly, are there any other treatments like those interferons or treatments that have that same effect that might make one disease worse over another, or maybe not address the issue with the disease?
Yeah, so Julie, I think you're bringing up a very important point, and that is, why are we taking so much care and putting so much importance on an accurate diagnosis? And it really is to institute the right treatment plan. And there are treatments that do make MOGAD worse that are used in patients with MS, and that includes interferon beta, to some extent, maybe also glatiramer acetate or Copaxone. What we've also learned is that MOGAD patients, if you take on average, don't respond as well to B-cell therapies as MS patients do. There are some patients with the MOGAD who do respond to B-cell therapies, and we're still trying to understand the nuances of that response. So I think there are some very important treatment response differences, and many of the MS treatments have not been tried in large numbers in patients with MOGAD, but we do know that certain treatments do work better in MOGAD in preventing relapses, and this includes IVIG and to some extent mycophenolate mofetil, and in a small subgroup, rituximab.
Ah, okay. Interesting. We do have a community question. I kind of want to interject it just to make sure we get it in. So this person is asking, how will you know if you are monophasic or have a relapsing tendency according to that criteria? Like what are the criteria?
Yeah, so the criteria don't address monophasic versus relapsing at this point. And we had a lot of discussion in the panel about whether this should be included. We felt that this is the topic of another study and analysis, and that it really would not fit into the current MOGAD criteria. But I agree, it's a very important distinction. And really that is the major question, is predicting and understanding which patient with MOGAD will have future relapses. There are different types of relapses, and there are some that tend to occur shortly after a diagnosis or an attack of MOGAD, and this could be different phenotypes. And then there are other relapses that occur a year or 2 years or even 5 to 10 years later. And it might be important to differentiate those types of different attacks. And we might even have different treatment strategies to prevent these different types of attacks. Now, how to predict if you're someone who is going to have an attack. So age is a predictor. We know that older age at diagnosis or onset is more likely to have attacks compared to especially children, or especially patients who present in the 3 to 5 year age range. Also, the type of first attack that you have is also a predictor. And again, very young children who present with ADEM very, very rarely have another relapse in the future, compared to patients who present a little later in life with optic neuritis or an NMO phenotype do tend to be more likely to have relapses.
Wow, that's very interesting, and also very personal for me, because I've had this for about 23 years and untreated for probably 14 in the beginning, with very long spans of up to 8 years of supposed attacks that I remember, and they were very, very different than the optic neuritis I ended up with. So thank you. That's the further the research goes, it'll be great for patients to start to understand that, so thanks. I do want to just kind of go back to the testing, since we've answered that question. So there's MS patients out there, and they may have MOG, or maybe they're worried about it. If you were to say to an MS patient, who should be tested for the MOG antibody?
Yeah, so I think patients who have atypical presentations, and this could be ADEM or bilateral optic neuritis, or spinal cord lesions that are very long, what we call longitudinally extensive spinal cord lesions. Those patients should be considered for MOG testing. Now, as I mentioned, the MOG antibody is most often positive at the time of an attack. So if you go in for testing and it's negative, it might not rule it out. The caveat is also that it might not be best to keep testing as well, or just to go in for a random test. It might be better to check with your neurologist and ask, if I do have an event, then I should be tested, and that would have the highest yield.
That's great advice. And I honestly think, that really will help patients a lot. I think it's a big point of confusion, because originally we thought, well, why not test everybody? But there's a lot to consider in that, especially with these low titers getting it during attacks. So important information for everybody. So we're kind of coming to the last question we have, but it's a really important one for us. First of all, is there anything that you want to tell us that you're working on that patients would find interesting, or anything that we didn't touch on that you'd like to pass on to us or let us know?
Yes, so Julia, I'm very excited about work that we're doing in the laboratory, where we are looking for a biomarker to predict relapses in patients with MOGAD. So we have some preliminary results. These need to be what's called validated or checked in other cohorts, and we're working on doing that. And I'm very excited that this type of work could help to identify patients who are more likely to relapse and maybe even head off a relapse. And then there's also a great deal of work going on in the community around treatments. And so there are several clinical trials that are being initiated in patients with MOGAD, and I'm very hopeful that these will lead to approved therapies, and that will make access to treatments much easier. And lastly, I'm also very excited about this international panel, diagnostic panel work. And I think that further validating these proposed diagnoses and refining them is going to really help to diagnose MOGAD and make sure that we are both diagnosing and treating patients appropriately.
Wow. I mean, those things are all super exciting. And, I want to say how excited I am, because this power panel is just great. And honestly, we imagine that we'll hear more from them. And now that this proposed criteria has been put together, it's exciting to see what's coming in the future. And certainly that research on predicting relapses would be probably a life changer for a lot of people if it gets developed. And so thank you. Thank you from the bottom of our hearts for doing that kind of work. And also thank you for joining us today. We're pretty happy that you've put out all this great information for everybody.
My absolute pleasure. Thank you for having me.
Okay, take care, and we'll talk to you in the future sometime. Check in again.
Thank you. Bye-bye.
Now I'd like to switch over to part 2 of our MOGCast. And we have, as I mentioned earlier, Abigail Vacca. She's from the National MS Society MS Navigator team. Welcome again, Abigail.
Thank you.
Good to see you. So I want to talk a little bit first about the National MS Society. We've recently, kind of started a collaborative partnership with you all, and we love the work you do. We're excited to let patients know about the MS Society. So please tell us a little bit.
Absolutely. So the National MS Society has a really interesting history. It was founded by a woman named Sylvia Lowry over 75 years ago in 1946. Her personal connection to the disease was her brother Bernard, who was experiencing different worsening symptoms like balance issues and visual impairment. So this amazing woman put a classified ad in the New York Times to see if anyone had recovered or found a cure. And instead, she got a host of replies from people just as desperate to find an answer. So in response, Sylvia, and I want to emphasize, she had no medical background herself, gathered prominent scientists and medical experts to help her establish the National Multiple Sclerosis Society. And we are a nonprofit organization that assists individuals across the United States, Puerto Rico, Guam, and the US Virgin Islands. And I just think it's amazing that her perseverance has directly led to more breakthroughs than has been seen for any other neurological disease.
Wow, we had no idea. That's a great story. How amazing, that just a grassroots, what started out as a grassroots organization could turn into what it is today. Um, wonderful to hear about it. So tell me what role this MS Navigator plays in helping patients who approach the National MS Society.
So MS Navigator really is the flagship program within the National MS Society. We're often the first staff members that constituents who call in will interact with. MS Navigator was launched in 2017, and we can provide a host of information and resources on internal programs and services available. Some examples are helping inform callers about all of the valuable information on our website, which is available 24/7, such as the virtual brochures on almost every topic imaginable. And constituents often don't realize that we have all of this information right at their fingertips on topics from sleep issues to driving with MS. We also frequently connect callers to different programs like Ask an MS Expert, which is a program where you can learn about trending topics from an expert in the field. Our Hispanic, Latinx, and Black Experience Summits, as well as the smaller touch points like signing someone up for our Momentum magazine so they can stay connected with the latest research and news. So those are just a small sampling of some of the supports an MS Navigator might reference. And then, of course, we also have information to connect callers to things like how to find a clinical trial, financial assistance resources, and so much more.
That's quite a bit. Very, very nice, portfolio that they offer. I just, I guess I have a question about what types of patients they help. Do they help patients with MOGAD or maybe other demyelinating conditions like NMOSD, ADEM, or transverse myelitis, including patients that have MS?
We do. So some of the umbrella disorders we have gotten calls from include MOGAD, as well as Alexander disease, ADEM, clinically isolated syndrome, neuromyelitis optica spectrum disorder, which is also known as NMO. Stiff person syndrome, I definitely want to give that a call out as it recently gained prominence due to Celine Dion's diagnosis. Transverse myelitis, and those are just a few examples. And there are a few more, but I won't necessarily go over them because it's an extensive list. So I would say if you have one of these conditions, we can definitely connect you to information and resources, just like if someone with MS were to reach out. And just one example of a common resource that's incredibly helpful that I'll probably reference quite a bit throughout our conversation is NORD, the National Organization for Rare Disorders. They are a wealth of information and often can connect constituents with the organization for their specific condition, which is so critical to making the right connections.
Yes, they are a wonderful organization, and so people should also pay attention to them quite a bit. So you touched a little bit about some of the services that are available to patients. Could you maybe have a little bit of an more extensive discussion on that, as well as maybe some of the services that you don't offer?
Certainly. So I'll emphasize MS Navigators really try to utilize internal resources. Some of those include financial assistance. We do also have case management as well, which is really meant to be short-term assistance for people who are presenting with the most complex needs that an MS Navigator can't necessarily address. So this allows us to still ensure we're able to try to find solutions for issues people have, connecting with programs such as food stamps, energy assistance, etc. In regards to services we don't offer, some questions we get more frequently include if we have legal assistance on staff, for example. We do not have lawyers, occupational therapists, or PCAs within the National MS Society. That being said, I want to emphasize that when there is no specialist internally at the National MS Society on a specific topic, we try to make sure we're well versed and connected to other organizations nationwide, so we know who the experts are in that area that we can refer out to. So, for example, we may not have an expert on educational IEPs or 504 plans within the National MS Society. However, if someone feels that their rights have been violated and they or their child isn't necessarily getting the services and accommodations through their school that they should be, we could suggest that they go to the Office for Civil Rights or another resource to file a complaint. Another example of a question we frequently get is around ongoing counseling services. So while the National MS Society doesn't provide mental health services internally, again, on an ongoing basis, we are going to support people emotionally during a difficult call and strive to get them connected to mental health services in their area. So bottom line, I hope the takeaway is that MS navigators always strive to at least be able to connect individuals to some sort of services that would best meet their needs based on their specific situation.
Well, that's a great overview and a deep dive, all in those couple of questions that you answered. So, just to, get a really good feel for people that are listening, could you walk us through one of your initial intake calls? What are the goals of the Navigator team during that initial call for the member, and how do you approach meeting that patient's needs?
Sure. So MS navigators are trained to serve as supportive partners, and we try to help navigate any challenges unique to each individual situation. So our goal is always to assess their financial and emotional needs, and we try to look holistically at the whole picture. So some of the ways that this is accomplished is by discussing family, friends, and other available sources of emotional support, such as self-help groups if they're not already connected, or online communities. Discussing the impact of diagnosis on family, including children. Assessing and advising on employment and health insurance status as well, such as reviewing disclosure options, planning for the future. And I'd like to call out that we actually have a benefits and employment team internally who can help guide constituents through some of those pieces as well. And I think it's worth mentioning that that's the most common topic we field questions about is benefits, insurance, and employment. And we also field a host of questions around, again, social and emotional support, housing, neurologist referrals, home care, and information on disease-modifying therapies and specific symptoms. So at the core of our assessments, we really, again, want to work with the individual with MS, with the umbrella disorder, or a loved one toward finding some sort of sustainable solution in meeting basic living requirements through connecting with those community and social service agencies. And so we screen for eligibility for state and local programs. We potentially provide phone-based guidance with completing applications. We try to help people understand forms and other necessary paperwork to access those entitlements, because that can feel just incredibly overwhelming. So if you call And we ask a host of questions about gender, ethnicity, veteran status, and other demographics. That's why we're trying to figure out what you might be eligible for. And then from there, MS navigators will close the loop by following up where needed after that initial call to confirm whether the person did receive those entitlements and try to continue to advocate on their behalf as the situation requires.
Good answers. That's very helpful to people. So some of the people, one of the big topics that we have in the MOGAD community, just because it's a new disease, we have no FDA-approved medicines. People have, trouble getting insurance approval for their medicines and navigating insurance, especially, including Medicaid and Medicare. Is there something that the MS Navigator team can help with in that regard?
That's a great question. We can definitely help guide towards the best insurance options and help constituents try to get to the root cause of the issue. So we receive a lot of financial assistance resource requests for medications as a result of things like, well, bottom line, the cost being too high, sometimes due to things like cost sharing, tier or formulary changes, other restriction issues with a specific insurance plan like step therapy, or it might even just be a need for prior authorization. And so we're often asked to help with appeals and denials of coverage. So we will connect people with different patient assistance programs as needed, as well as available pharmaceutical assistance programs.
Oh, good. That's very helpful. Thank you. So one of the other things that people look for are services to help find physicians to not only treat MS, but MOGAD and other rare neuroimmune disorders. Is this something that the MS Navigator team can help with as well?
We do have our Finding Doctors and Resources tool on the website, which allows you to search for a host of different types of healthcare providers. So while it doesn't specifically call out medical professionals versed in MOGAD or other disorders similar, there are a few different routes we suggest constituents take. So first of all, you can look for a neurologist and advocate for them to do the antibody blood work to rule it out. Another suggestion we often offer is that you can try reaching out to your insurance company to see, again, if you're insured, to see if they can help you locate any specialists. Another option that we frequently suggest as well is to connect to an organization like NORD, which I referenced before. And then further, another route is for constituents to try reaching out to one of their healthcare providers they're already seeing, like a PCP or, again, a neurologist, to see if they know of specialists. Word of mouth is incredibly powerful.
It sure is. Yeah, absolutely. Well, thank you. So how can patients contact the MS Navigator team? Is it email, phone, etc.? Anything you have to say about that?
Yes, so there are multiple ways someone can reach out to an MS Navigator. We're available Monday through Friday by phone, and our phone number is 1-800-344-4867. And we're available 7 a.m. to 5 p.m. Mountain, which is 9 to 7 Eastern time. And individuals who wish to speak with the Spanish-speaking MS Navigator will be prompted to press 3. Definitely want to call that out. We are also available throughout the day by chat on our website, and we are available by email as well at contact us, nmss@nmss.org. And all of this website is on our website, so there's no need to try to memorize it. And I'll just add that our email box is monitored daily.
Oh, that's great to hear. That certainly covers a lot. Is there anything else that you want to convey to these patients that are listening regarding the MS Society and the MS Navigator?
I think MS Navigator is just an invaluable and professional service that's offered at no cost. So if you have any questions, please don't hesitate to call. We really just want to help people cope with and navigate their journey, whether it's right at the beginning where they're trying to figure out how to handle their symptoms and explain it to their families, and get connected with doctors or treatment. Or if you're at the other end of the spectrum and you're further along in your journey, we're here for you, period. And this service is open to care partners and families of individuals living with these conditions as well, who are just trying to provide them with support. I'm just really proud of the work that this team does.
Well, we're certainly happy to hear that you are doing that kind of work. And, this is invaluable, as you said, and we're happy to pass it along. And so that kind of leads me to my last question. How can patients support the National MS Society?
It's a great question. Well, you can start by visiting our website. Of course, we always hope that individuals will consider participating in some of our fundraising events like Walk MS, Bike MS, which also can serve as a really great way to start building community, I would say, especially if you're at the beginning of your journey. And then, of course, there are other ways that you can get involved, since we're a nonprofit. So in terms of donations, funding helps us move research forward so we can find a cure. And we really are getting closer and closer every day. And then I would also call out our fantastic advocacy community and encourage patients to become MS activists. And within that community, you can work to help educate elected officials on different policies that would benefit individuals living with MS, people living with chronic conditions in general, and their support networks.
Wow. Yeah, there's certainly a lot of things that patients can do. It sounds like even creating some exciting or attending some walking events, that sounds like a lot of fun. Or whatever you have. Fundraising events are always a good way to build community. So I would encourage people to go out there and take a look at your website. Abigail, this has been a great conversation, and it's certainly been I think invaluable, not only to MS patients who are listening, but certainly the MOG communities as well. So thank you. And we'd like to also thank Dr. Chitnis for joining. So for both of you, your time and commitment has been amazing to both of these types of patients and others as well. And so we look forward to providing this on our website and our YouTube channel, and eventually on Facebook. And we apologize again for not being able to connect to Facebook Live for this, but we will be collecting any questions that patients post, and we will have a follow-up MOG blog, as I said in the beginning, any of those questions that went unanswered. And so this was a great discussion. And again, thank you and have a great afternoon.
Thank you for having me. This was a true privilege.
Thank you. For us as well. Take care.